Thank you very much for the kind invitation, introduction. Thank you, Felix, for inviting me. I'd like to have my slides, and hopefully I do understand how this is working. How can we? Green button, okay. So may I have the slides, please? After we've heard now very much about how to repair AVSD, how to repair complex AVSD, the question is now, how do we treat these patients when they come from the operating theater? One of the main things always from the surgeons to the intensivist or the cardiologist is extubate them, send them to the ward because then they are fine. So that's the basic concept. And the intensivists say, wait a little bit. Let's assess the patients first and see whether this is really a good idea or not. And my talk, which I have the honor to give here, is about this little issue in between these patients, what to do with these patients. And we've heard a lot about these anatomies, basically the normal heart, and you have the complete AVSD, and we've heard that we have different forms of AVSDs, the partial, intermediate type, or incomplete, and the complete AVSD. Basically, the idea is that this is an ASD hemodynamic, and this is a more VSD hemodynamic, plus minus the significant AV valve problem. And the difference between these is here, you operate on a healthy child. These kids come to surgery and they're fit and healthy and have the problem. And here you more or less operate on very sick babies. And so that's the very, very big difference between these two sorts or three sorts of patients. And if we have heard a lot about the results here already, and I didn't want to quote the Melbourne or the Berlin the German Heart Center in Berlin results, so I give you a little bit more historical. Two short studies. One is from and one back is which one? The left one here. So one is the of 1995. The overall mortality was about 8%. However, this is an early mortality. So we're talking about mortality here in the early phase, at the early post-operative phase. And we've seen the pictures from Melbourne now, which basically reflects exactly the same. If you look then why these patients have died, you see, as has been mentioned, there's pulmonary hypertensive crisis, acute ventricular failure, and a little bit sepsis, which is for the small babies again. And again, the risk factors for early death, we've heard this already, is pulmonary hypertension and severe left AV valve regurgitation in the immediate postoperative period. And again, these patients at risk are those who have preoperatively already a severe left AV valve regurgitation. So these are the patients at risk. Next study from the Netherlands from 2010, basically the same idea, 300 patients, 8% death. Younger age, so the young patients who required surgery early because they had the sick babies. What's the main independent risk factor for death in this patient group? And if you look, common, partial, and intermediate type AVSD, you have AV valve insufficiency, which is the main part. You have patients with Down syndrome, and you have the smaller babies who are the patients at risk. If you then look at the trends, what is operated now, and we have seen this, one back, you have here the two green buttons. The patients are operated much, much earlier, so they're younger. And the in-hospital mortality has something to do with cardiac failure, and these are the patients, the small babies, the sick patients, long bypass time, who have a problem after surgery. And those septic patients who are sicker, maybe because they enter the theater sicker, and perhaps they may even acquire sepsis. There are guidelines, and we have basically seen all of the presentations that all what is presented here is according to the guidelines, that the standard AVSD should have surgery between 3 and 6 months. Basically, these are the patients with volume load, pulmonary hypertension, AV regurgitation, and heart failure. And the other ones, they are operated later, 3 to 5 years, depending on the AV regurgitation, or even before school age or at school age. Why is early extubation something good? Why is fast tracking something good, or is this something new? Basically, this is an old story, 1992. The first reasonable ideas about early extubation of ASDs. 19 children were extubated in the operating room, but these are the patients who had a shorter bypass time, lower fentanyl dose, which is a lower anesthetic regime, and they had a shorter stay. And basically the author thought this may be an advantage for the patient to be extubated early. So it may be beneficial for the patient. The next big study in 1996, again, ASD patients. However, these patients coming to the ICU, but these patients had a little bit more respiratory acidosis. and an increased vomiting. So, yes, you can extubate them, even simple ASD patients in theater, but apparently they are not as good as if you ventilate them a little bit longer. So, to conclude for this little first easy cases, the basic idea is that you have these incomplete AVSD or the intermediate type. Basically, these are healthy and older children with a heart defect who go to theater healthy, and basically you can have them operated quite early. You should, however, assess them postoperatively because there are the cases where you have this very fast track. I think it's possible, but it's not really an advantage for the patient. You should assess them in the ICU. You should have some assessments like echo, rhythm. You may have a look at the chest X-ray. There may be an effusion. You may think of draining because the pleural cavities has not been opened in theater, etc. You should have adequate pain therapy for these patients, and you should give physiotherapy. The chest should be clear, and then you extubate them quite early, after 2 to 4 hours in the ICU, and then they're fine. So that's the story for the easy cases. Now, what about the more complex cases? The complete AVSD, basically, you know that we have an operation age is 2 to 6 months, depending on the clinical status and depending on the pulmonary hypertension, as has been mentioned by Christian Bejar. Preoperatively, you have the sick young patient. This is why these patients go to theater. And some of them are ventilated, some of them had bronchiolitis before, some of them have pulmonary hypertension or elevated pulmonary resistances, some of them do even present with heart failure. And mitral valve function or left-sided AV valve function is the main key factor which comes to this. The defect itself, as I said, causes pulmonary hypertension. You may have atelectasis, you may have inflammatory processes in the lung that may impair the postoperative course. Surgery itself, you've seen the explicit explanation how the AV valve is assessed. This all takes time, so you need time to do surgery, you need bypass time. And bypass, the longer the bypass is, you may cause a systemic inflammatory response. You may have rhythm problems afterwards, you may even develop jet. Low cardiac output syndrome is another problem. Small babies, sick babies, long bypass times, they may create this. And you may have other effects, and specifically trisomy 21 may be a risk factor for these patients. So is it a good idea to extubate them quite early in theater, yes or no? And so I looked a little bit and tried to find some facts that may give you an idea whether this is, in my opinion, good or not. First of all, you have some other defects. And the problem is when you look at fast tracking, many of these patients are mixed. We know from Fontan patients that you can do this, and because the respiration has an excellent effect on the Fontan hemodynamics, it's a very good idea to extubate these patients quite early, even in theater, because you support the circulation in these patients. So in these patients, yes, that's a good idea. And you see this, the amount of extubated patients in theater goes up, but these patients, again, these are older patients and basically healthy patients. They are cyanotic, but the heart is working quite nice, they have low pulmonary resistance, they go into theater early, and they go into theater safe and healthy. So it's not really a good idea to compare these patients to the patients we're dealing with. The next is another study about Fontan patients, basically has the same result, that these patients, you can extubate them early and you have improved postoperative hemodynamics. But again, Fontan patients are not the AVSD patients we're dealing with. Now, if you look, again, if you have patients coming from the OR to the ICU, and pulmonary hypertension is one of the key factors, you see there's 102 patients, just a whole mix of patients. They come to the ICU, and the CO2 was 52, and the pH was lower, 7.7, and we know this is a trigger for pulmonary hypertension. So we know these patients in our AVSD group, these are the patients who then are at risk to develop pulmonary hypertensive crisis or significant pulmonary hypertension. And the group from Ricardo Munoz from the United States, they have looked at 200 consecutive cases, and they looked whether these patients were able to be extubated in theater. 58 of those, which is around about a third, were extubated in the operating, another 2/3 were extubated within the first 24 hours, 2007. What were the criteria to extubate them? Basically, simple intensive care unit. They have to be awake and appropriately neurologic comprehensive. You have to have a look at the heart, whether the heart is fine, whether there's a mitral valve regurgitation in our cases, or a residual VSD. You should have a chest X-ray without significant pathology. Again, the AVSD patients. You should have an adequate blood gas. The ventilator should be fine. You have to look at the trachea. You have to look, is there any much secretions or not? And they have to be hemodynamically stable, which means a low inotropic support in that area, a little bit of catecholamines and milrinone. If you look at the patients that have been successfully extubated, again, these are the patients, the AVSDs, the REG score 3, and only basically 60% have to be extubated within the first 24 hours. So our patient group, despite all these efforts that made, they are patients at risk to be early extubated. There's a big retrospective study from Mr. Mitnacht from the States again, and they are the ones who, if you look at the literature, they proposed most early extubation in theater patients. The first study was a retrospective chart review of 224 patients, again 2008, and they said, okay, the strongest risk factor for the failure of this strategy was younger age and longer bypass times. These are the AVSD patients. And if you look, again in detail, complete AVSD was only extubated early in about 40%, and even the partial AVSD extubated in 60%. So, with all the efforts, retrospectively, AVSD canals, they really do not fall into this scheme. The next big study of the same group, with a connection between a Japanese group and an American group, was a prospective study. Again, around 300 patients. And they analyzed and looked what was the risk factors why they could not extubate these patients early. It was those patients with a REG score 3, AVSD is REG score 3, trisomy 21, and age again were the factors that came into play. And if you look in details, you see here REG score 3, 70% were deferred for early extubation. REG score, they made a point system, a scoring system to find out what is the risk factors for these patients. Younger patients with complex anatomy were these patients at risk, and patients with pulmonary hypertension were those patients where the anesthetist said, we have to be careful, we should not extubate these patients early. And here the univariate and multivariate analysis, the risk factors, which trisomy 21, pulmonary hypertension, and the younger patient's age. So then, last study, or one of the last studies, was a longer study, which was basically 600 children. So the studies get bigger because the idea of early extubation gets more and more attractive, so including a whole lot of 100 neonates. Intraoperative extubation was 71%, and early extubation in around about 90% of the cases. That's a big, big number, and this is a big, big effort. However, if you look into detail, most of these patients, even the neonates, have been somehow healthy patients. Not those sick patients with pulmonary hypercirculation, AV valve regurgitation, heart failure before, and etc. If you look at the AVSD patients, round about 60% only in theater, and then after 1 day, around about 100%. And the risk factors, again, the 2 to 4 month group, again, round about the same time, more of them were not extubated in theater, but they were brought to the ICU, assessed by the team, and then they were extubated thereafter if they were stable. Last but not least, I'd like to congratulate the colleagues from India. And we have Krishna Kumar here, and I do know the setting here in Bangalore. This is a pretty very busy unit. They have around about 120 beds in the pediatric cardiac ICU. Around about 60 of them are ventilator beds, so that's a big ICU, and they have a high throughput. And they analyzed, because India, even it's a developing country, and I visited this center, so I know what they're talking of. Even if it's a developing country, they make a really, really good job. And they looked at about 1,000 consecutive patients, 1.5 years' time, I think. This is the time which came in, and they compared them to a historical group of another 1,000 patients. And they tried with a very, very definitive anesthetic regime, etc., to promote early extubation, to have more possibilities for these patients to be extubated early, to shorten intensive care time. And they were able to extubate 87% in the theater. And you see the details, there's a whole, everything what you can imagine has been extubated in the theater. However, neonates 40%, and the younger patients to a less percentage of early extubation. Again, if you look at the overall cohort, this was possible without an increase in mortality and morbidity, but with a significant decrease in ICU length of stay and less use of hospital resources. Again, if you look at the neonates, you had a significant number of neonates and small children, and the percentage of extubation was the smaller, the younger the patient was, the more early extubation was deferred in this patient group. And if you look at the AVSDs, yes, many of them have been extubated early, but this comes to a price, and the AVSD group is the group where they had some of the mortality in this group. So, if you put all this together, this data which I've shown you, and there are much more studies around, I'd like to come back to the original slide and just have back the idea that, okay, if you look at the age of population, we have the younger patients, the sicker patients, we have patients with heart failure, maybe ventilated, and most of them have pulmonary, all of them have pulmonary hypertension, most of them may have, even at this age, a little bit elevated pulmonary vascular resistance. The lungs always have a problem. You may have significant arrhythmias. We're talking about longer bypass time in small children, and we talk about children with trisomy 21. So if you then try to come back to this question, early extubation, yes or no, I'd like to give you this little bit conclusion or proposal from my point of view. First of all, I think in these AVSD patients, and we're talking just about the AVSD patients, I would not recommend intraoperative extubation. I say better safe than sorry. You do not do anything wrong if you defer extubation from theater to the intensive care unit. Then you have to look at adequate postoperative nursing and assessment. Mind you, all the studies I showed you, they have a one-in-one nursing. In India, they have a one-in-one nursing of all ventilated patients from theater. So it's a one nurse at the bedside all the time. And you have to have this continuous monitoring and dealing of the patients to be sure that this patient is in a safe environment. Then I'd like to ask you to look at the clinical status. You have to do all the homework, what the intensivists have to do, look at echo, you have to manage low cardiac output system, you may have to treat pulmonary hypertension, etc., etc. And if this all is fine, I'd say extubate the morning after. The patient is operated in the morning, then you wait, you come back, you have the wonderful night then, and then next morning you assess, and when the night was stable, then extubate. Because what we do not want in these patients basically is the waking up in the morning after with all these questions, should I have done something different? Thank you very much.